LSVC with PS stenosis, sir. PS stenosis.
PS stenosis. Can you kindly run the angiogram now? Yes, you know, I think you're tying yourself in knots, actually.
Just
So the code says, so how has the catheter reached the LSVC from the IVC? You didn't tell us that.
Sir,
Okay.
Sir, this will be from IVC to RA to coronary sinus to LSVC, sir. This will be the course, sir. This is,
Okay, so can we have the answer, please?
Yeah, so what's the answer? You said no, LSVC, go on. Tanmay? That's
LSVC.
LSVC to?
So LSVC to coronary sinus to RA, sir.
Okay. So we move on to the second question. We grant them 10 marks.
How many marks they have to get for this?
Yeah.
If you have been satisfied with their answer, you give them 10 marks.
Yes.
I know you're a harder nut to. You're a much more difficult person to satisfy. From experience, I can tell that.
But 10 marks and move on to the next question. So team 4 now. Can we get the second question? Okay, very good.
We'll give them a little longer time, sir, please.
Okay, okay. So the boss says that you get more than 60 seconds.
There's some issue with the timer, so I'll just check that.
Yeah, I am not seeing the timer actually on display now.
Yeah, I know, sir. There's some technical issue. I'll just check.
I'll keep time. It's okay.
It's the pigtail catheter in IVC angiogram showing a filling of a portal vein, which is going and draining into the.
Just keep running it, please. Keep it on loop mode. Yeah.
Don't stop the angiogram. That's right.
Can you, one second, can you keep it on loop mode, please?
But actually, there's some issue for this time.
Okay, just keep running it. Please keep.
Yes, go on, young man. You were saying something.
Yes, sir.
Go on.
Sir, probably a porto systemic connection suggestive of Abernathy malformation.
Okay, which that's not enough. So Abernathy malformation is of different types. Would you want to go beyond this, or you would want to say that okay, this examination is not enough to answer that question? But don't worry, we will grant you the credit.
Now, what would you like to do next? That's what Dr. Sanjeev Sharma is asking. Are you happy with this angiogram, or would you like to refine your, like to do something else to make the diagnosis more obvious? Are you seeing the portal veins? Is the question that we are asking. Yes or no?
So portal veins radicals, are you able to see them or not see them?
What are you seeing inside the liver? Are they the portal vein radicals, or are they something else? Now, you don't need to get nervous because you got the answer. You just need to refine it a little better.
We will give you 10 marks. Don't worry.
But you are expected to get this right because in Chitra, you've seen quite a bit of all this. What would you do next?
We will take a balloon occlusion angiogram. We'll take to delineate the radicals in the liver.
Are you able to see any portal vein radicals in this one? Yes or no?
No, sir.
No, because what you're seeing is not portal vein radicals. They are hepatic vein
tributaries only. We have to occlude and then see, sir.
Go the next angiogram.
To see portal vein radicals.
Priyanka, next slide. Priyanka, next slide. Yes.
So why do you want to see portal vein radicals? You didn't answer that question.
To know exact site of communication, sir, between the.
That's not important. That's not important.
Second answer. Okay, now show the next one. The second one. Yeah, this one. This is the balloon occlusion angiogram, where you are able to see the portal vein radicals. Actually, you are able to see it in the second angiogram in the selective injection as well.
So why do we need to see the portal vein radicals? Because so this is team 4 answering, right?
Yes, sir.
So we will move to team 3 to get this answer right. We will give them bonus marks if you get it right. So why do we want to see the portal vein radicals?
All India Institute. Why do we want to see the portal vein radicals?
And if Sampath doesn't tell us, then we will, give him some negative marks, because this every other week we see this. Yes.
Why do you want to see it, Sampath or Ram Manohar?
Okay, not so much time. So we move on to team 2 to answer this. Bonus points available for taking. See, you either know or you don't know, because Angio is not going to answer this question.
Why do we want to see portal vein radicals? I'll ask one more question. What else do you want to record while you see the portal vein radicals? Some pressure you want to record. You see
Team
the
2
last
in spotlight.
So team 1.
So I think we should give the move on, sir. We'll give the answer and move on. No.
So our treatment strategies basically revolve around the presence or absence of portal venous radicals. Because if we do see portal venous radicals in some way, we will close this. But we need to measure the pressure before we take a decision on treatment. In this index patient, the device closure has been done for this, and that's what we would do. But the two important things is pressure as well as the presence or absence of portal venous radicals. Okay, we move on to the third question. So that's team 3 now.
And this is incredibly easy. So you can have some quick.
Can you run the angiogram, please? 10 seconds for team 3. Yes, what angiogram is this and what does it show?
Team 3.
We are doing basically we are doing a pulmonary venous wedge angio. We are seeing the pulmonary there is a pulmonary attrition there. We are seeing the bilateral pulmonary arteries filling.
What is the key word what you are looking for, which is filling? Keyword that you are interested in.
There is a malformation there, and then we can see that the filling is like the pulmonary arteries are filling.
So this pulmonary venous wedge angiogram is done to see pulmonary arteries, something in the blank.
Sir, I meant, sir, probably there is pulmonary atresia. So we have done a venous wedge, and then we can see that there is also filling of the pulmonary arteries.
Yeah, but the word which you are looking for, which everybody is looking for, is.
Sorry, AV malformation was there.
Dr. Don't speak too much now. Dr. Sanjeev Sharma will start giving negative marks to you. So
exactly, now we start moving the other way. Okay, team 2. I gave you half the answer actually. It starts with C.
I think I gave it fully, but they didn't pick it up.
2 marks available.
We were actually missing, sir. Sorry.
Nothing's missing. You've had enough to see. You just have to give the diagnosis.
It's too simple and too straight to. So we will not give bonus marks to anyone. But your answer is correct. This is a pulmonary venous wedge angiogram to demonstrate pulmonary artery confluence and pulmonary artery size. So what the word which you had to say was the confluence. That's why we used to do this. We no longer do this with the advent of orthogonal imaging. We really don't need this.
So it's not all that simple, you realize.
We move on to the next team. So next question for team 2. Please move to the next slide. Yeah. Okay.
What is the marks for this? You have to tell them.
They get 10 marks. All right.
So they got it all right. Now we'll go to team. Now we are with team 2, isn't it? Yeah.
Team 2. So this is a very straight answer. Quick. What catheter course, what angiogram, what does it show? Please run it again. Somebody is keeping track of the time. We don't see the timer anymore.
Yeah, so there's some technical issue with the timer. I'm just
We
fixing
are
that.
on track, sir. We are on track. Not a problem. Can you just run this, please? What's happening, Priyanka? I can't understand.
So I think I just try to reshare my screen. So I'm very sorry about that. There's some issue because the slides are keep
Can
on.
I share the screen? Can you let me share?
Yeah, sir. You can.
Second, and I'll find the angiogram.
Coming from the right.
Let me share the screen. Give me a second. I'll just share the screen.
Actually, KK sent me these angios in the afternoon, but I couldn't run them either, in fact, on my laptop.
Are you able to see this angiogram?
Yes.
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 And now you can see it's running quite well. So you don't worry, you can see from here. I'll let you see this and I'll keep running this. We can start the timer now. That's fine. You have to give a simple diagnosis, team 2, Jayadeva.
What is the catheter course? Where is this catheter? What does it show?
So it's a pigtail catheter and doing an RV angiogram, sir.
Very good.
The pulmonary artery is getting filled and
Diagnosis now.
Diagnosis.
so pulmonary AV malformation, sir.
Pulmonary AV malformation.
I think we have to move on, sir. That's an incorrect answer.
No, that's pulmonary AV malformation. Would you do it?
It's a pulmonary stenosis, sir, at the infundibular.
Okay, we move to team 1.
Team 1.
A bonus point for you. You've
Team
seen
1,
this.
Kartika. Is Kartika on?
KK, can you kindly freeze it here? Freeze it here.
I'll just freeze it, sir. 1 second. I'll just freeze it. Yeah, this is good, sir.
Yeah. Just one.
Sir, what were the marks for team 2?
For this angiogram, 0.
0.
Okay, sir.
Now you have to, I'm holding it here and they are asking team 1, what was the diagnosis?
Team 1 has not answered.
Sir, double chamber RV, sir.
Oh, very good.
Excellent. So you get 2 points. So team 1 gets 2 points. So this is a double chambered RV. What you can see clearly is a below the pulmonary valve, another chamber, and the two are and the main body of the right ventricle are separated by an abnormal tissue. So this is a double chambered right ventricle. We move to the last question, and that is for team 1. So for this round, team 2 gets 0, but team 1 gets 2 bonus points. Oh, this is too, I think this is a 10-second spot.
Sir, I'll tell you, I think slides. Yeah, go ahead. I think Kartika and Sharmila.
Yes, sir.
Please tell us.
The catheter
Diagnosis and then
the catheter is in the pulmonary artery. The diagnosis is TAPVC, sir.
No, that's not enough. That is incomplete diagnosis. I'm sorry. TAPVC is, what kind of TAPVC is it?
This is a supracardiac type, sir.
But more precise.
That's not enough too. So there is another word which is missing now.
Supracardiac too?
Supra.
Here's another one for you.
No, don't do that, KK. That's not fair.
Pulmonary AV fistula.
No, sorry.
You have to stick to the same angiogram. Yes.
I'm sorry, it moved to the next slide. Okay.
Yeah.
So what is the supracardiac TAPVC is right. Now where to? You just have to say. That's all. Don't worry about anything. If you're getting it right.
So, see, diagnosis complete. LSVC?
Not the word, actually, more precisely. Phenomenal. Okay.
So we may have to deduct some marks from you now because we have to really extract the diagnosis out of you, and even now I still haven't got the complete answer. So what is this hugely dilated structure that you have here on the right side? Please, can you stop here, KK?
Yeah.
So in the right superior mediastinum, on the right up above the What is this? What is this huge dilated structure? RA. Oh my God. Above the pulmonary artery or below the pulmonary artery? You know, for a very simple, straightforward supracardiac TAPVC, is it obstructed, not obstructed?
That's a very important thing. Is it obstructed or not obstructed?
Obstructed
No, it's the wrong answer. It can never be
obstructed.
Incorrect.
Hello, sir.
It's incorrect.
Obstructed, sir.
No, sir. You're going on saying it's obstructed here, but it's not. It's unobstructed. You can't get such level of dilatation with obstruction.
You have to show what I was.
Older patients, you know, you can't get obstructed TAPVC survive to this age. So it is because of chronic increase in blood flow that these chambers get super dilated. You have figure of 8 appearance, and this is unobstructed. So we should probably give them half 5 points.
Okay, 5 points.
So the point I'm trying to make, Dr. Sanjeev, is that it's not that straightforward any longer with angiograms.
Okay.
Sure. Do you want to ask the next where it's draining?
I take back my words.
So it's vertical vein.
Yeah. So that's what is important.
Into RSVC, and then you can see because of the gross dilatation of the right superior vena cava, and then it drains into the artery. That is the top 8 of the figure.
Yeah.
So here's another example with the same thing, which you can see. Slightly different looking, but the same phenomenon is seen later on. You can see that there you see again. Okay. So these are all angiograms that are seldom performed these days, but the concepts are very well illustrated in the conventional angiograms.
Okay. So do we have an audience?
Yes, we do have an audience round. So
is the chat disabled?
Yes, sir.
Disabled, sir. But what we do now is just have the audience round, and I've got the questions. And this is something that I'm showing. It's a nice one. It combines.
Let me know, sir, when to start the poll.
You can start now. You can move this answer box to the side and keep watching your angiogram for the next 30 seconds.
Yeah, actually that is.
It'll be interesting to see how everybody answers. And then I'll offer an explanation. So I think most of the people have got it right. And that's very good. So this is indeed a right aortic arch with mirror image branching and with a PDA arising from the innominate artery constricted at its lower end and supplying the PA conference. And the access has been obtained from the axillary artery to enable ductal stenting. But the important thing to understand is that this is not a MAPCA. This is the duct. And this is very sensitive to prostaglandin. This can close down and the patient can become very cyanotic. And this needs to be treated like a duct. It's not a MAPCA. I think we are done with the angiogram round. I think we should look at the.
So while we are at this, it's just a trivia once, not actually a trivia, but this is an important message that you must always remember. So whenever you have to differentiate between a MAPCAs and the native pulmonary arteries, always remember MAPCAs are below the airway and the native pulmonary arteries are above the airway. So you see an axial section, and this is how you differentiate MAPCAs from a native pulmonary artery. Anyways, so that's it. So what is the status of scores?
So this is only from this round. We haven't got the cumulative scores yet. And I think we'll keep it this way. It's okay. We can announce it in the end. That's fine.
Okay, very good. Very good. Okay.
All right. Let's then move on to the next round. It's been fantastic, really. Thank you so much. So we'll move on to the next round. It's Rajesh Kannan, isn't it? Dr. Taragan, at any point you want to make any comments, please don't.
Yeah, no.
So, Dr. Rajesh Kannan, can you display your slide?
Is it Mahesh, no, sir, in the order? Dr. Mahesh
So Dr. K. Mahesh is for round 3.
Mahesh, then you can show Mahesh.
Yeah.
Please. I'm sorry, I missed
No
a
problem.
little bit. But Mahesh has also got very easy ones. And Dr. Sanjeev, you please, if you are still around, I know you're leaving at 7:30, but if you're still around, please sort of give your comments during these rounds.
Sure.
Okay.
Go to the first question. Yeah.
Just 1 second. Okay, I'm audible, I guess.
And now the team is, which team gets the question, Vishnu?
Sir, team 1.
Team 1 gets the question.
So we follow now 1, 2, 3, 4, 5 again.
Exactly. So team 1, Kartika and Sharmila, you start the question. Mahesh, you read out the question, and then we can start the time.
Okay, hi to all the contenders for the quiz. So this is an MRI question. Okay, so this is dealing with cardiac MRI. So I hope that all of you know that cardiac MRI uses different kind of sequences which we use for anatomical and functional evaluation of the heart. So in this slide, you're seeing 3 different sequences on the MRI. And each of them is capable of giving a different set of information. So what I want you to identify is which of these 3 sequences is the one that we use for measuring flows on the MRI. What is the sequence called? And it would be even better if you can explain the basic principles as to how this sequence works. So your time can start now.
C phase contrast.
Sorry?
C phase contrast.
C phase contrast sequence. Very good. So what does phase contrast sequence mean? Can you explain a little more? What does that mean? Can you also tell me what these other 2 sequences are? What is A and what is B?
The first one is a cine image. Cine image.
Okay. And what about the second one?
The reconstruction.
So it's a gadolinium enhanced MR angiography, right? So C is what you're saying is phase contrast imaging. So what is the principle of phase contrast imaging? What does it do? Do you know the basic principle?
We are not sure, sir.
Okay, so that would have been, perhaps I would have given you some bonus marks for that. So phase contrast is the sequence on the MRI that we use for measuring the flows. So this is based on the basic principle that moving protons change pace or their spin angle in proportion to their velocity. So during the MRI, you apply certain gradient pulses of magnetization onto these protons to induce phase shifts. And it is the signal intensity and this whole sequence is velocity encoded. So you have the different protons, the stationary ones that appear gray, the protons that move in a certain direction, one direction would appear brighter and the flow in the opposite direction would appear darker. Very much similar to what we see on the color Doppler, that the flow coming towards you is red and flow going away from you is blue. So similarly, you interpret phase contrast. So this allows for accurate estimation of velocity profiles of the flows across any valve or vascular structure. So I would give the team full marks, 10 marks on this.
Yes, sir.
Just be careful when you advance your slides. The answers are coming onto the screen. So it's defeating the purpose to some extent. So you go very slowly, advance 1 slide at a time, please.
Okay, so the next team, which is the team that is facing this question?
Team 2, sir.
So team 2. So this is a 13-year-old kid, and 12 years ago he had some kind of heart surgery and has just undergone a cardiac MRI. So look carefully at the 3 images that are there. The first image is an axial stack showing the heart, essentially trying to show the 4 chambers of the heart. And the second stack tends to show the right ventricular outflow tract. And the third is a flow-derived flow time graph across one of these structures. So the questions to you are, what is likely to have been the original surgery? What are the findings that you see on these slides? And how will this particular MRI study impact the future management of this patient?
Is the timer on display?
No, I can't see the timer.
Yeah. So there's some technical issue. I can't display the time.
Somebody feedback, please. So team 2, have you answered it?
Not it, sir.
Okay. How much time remains?
Maybe 20 seconds more.
Okay.
So this is an MRI done in a patient 12 years after congenital heart surgery. You have to look at the MRI, interpret the findings.
No more hints, Mahesh.
Yeah.
I think we'll move on now to team 3. If you got the answer, team 2, you want to take a shot at it? Just name the condition likely. What is the surgery likely? What was likely to have been done? Okay, team 3.
Sir, likely the patient might have undergone TOF correction.
Yes.
And we can see pulmonary regurgitation in the second image, the flow reversal, and even RV is dilated, RA is dilated, and RV appears slightly dysfunctional as well. And
so you get your bonus points for sure.
And how?
But you answer the second question.
And MRI findings, sir, like in follow-up of cough patients, like knowing the end diastolic volumes and RV function would help us for the indications of pulmonary valve replacement in this patient. Sir.
Excellent.
Very good. Excellent. Please give them 2 points as bonus. The next question comes.
Yeah, so you can see that the first image is clearly showing the dilated RV and also the RA. There is some mild tricuspid regurgitation. You can see the very dilated right ventricle and the dilated right ventricular outflow tract on the second image. You can actually see the pulmonary regurgitation happening. And the third, the flow time graph clearly shows how the regurgitation. You can see the flow that is going above the baseline 0 line is a positive flow, and the flow that is going into the negative is the regurgitant flow. So you use this information to actually calculate the pulmonary regurgitation fraction. And can you tell me, how do you decide on the basis of these images whether or not what is the next thing that would be required if the patient has this kind of findings, severe pulmonary regurgitation and RV dilatation? How is it going to impact our management? Can you tell us? Okay, so this helps us to decide our criteria regarding whether or not this patient merits a pulmonary valve replacement. Because if the RV gets inordinately dilated, there are clear recommendations for pulmonary valve replacement. And these are some of the criteria that are there. They're probably out of the purview of this particular quiz session. But if the patient is asymptomatic and if the patient meets more than 2 of these following criteria, where the RV end diastolic volume, index volume, is more than 150 ml per meter squared, or the RV end systolic index volume is more than 80 ml per meter squared. These are volumes that are actually calculated on the MRI. The RV ejection fraction being less than 47%, LV ejection fraction being less than 55%, large RVOT aneurysm, QRS duration of more than 160, presence of sustained tachyarrhythmias, or other hemodynamic abnormalities. So if you have more than 2 of these criteria, even if the patient is asymptomatic, it merits pulmonary valve replacement. Similarly, in symptomatic patients, it's enough if more than 1 of these quantitative criteria are met. And there are certain special conditions where the repair has occurred at a delayed age or more than 3 years of age. their special considerations may also come into play in our decisions towards pulmonary valve replacement. Okay,
Mahesh,
moving on to the next question.
Yeah, go ahead, please.
So, as we've discussed in the previous questions, we are able to derive the blood flows across various vascular structures on cardiac MRI. So now this is an interesting 18-year-old patient. I'm telling you the diagnosis. The patient has a VSD and a pulmonary atresia, and the patient has got aortopulmonary collaterals. So you can see this angiographic image where you can see that from the descending aorta, two collaterals are coming out. One is a stenotic collateral going into the right lung. The other is a very large collateral that is going into the left lung, which is labeled as LT. Now I put some numbers over there. These are the flows that have been calculated on the MRI. I'll just tell them for more clarity. 14.5 liters is the flow going into the ascending aorta. 2 liters of flow per minute is going into the collateral going into the left lung. 7.6 liters is going into the collateral going into the right lung. Okay. And then you also have the flows that are coming back via the pulmonary veins. So from the right lung, the flow that is coming back is 7.6 liters, and from the left, it is 2 liters. So I want you to use these numbers to tell me what is the likely QPQS in this particular patient and what will we infer from that. So you have all the numbers which have been calculated on the MRI.
Team 3.
So you have 14.5 liters of flow which has been seen on the ascending aorta. You have 2 liters of flow going into the left lung collateral, 7.6 liters of flow going into the right lung collateral, and similar corresponding pulmonary venous returns. So all you have to do is use these numbers and tell me what the QPQS is and correlate what these numbers, what it means to you.
So, sir, the QP would be 2 liters plus 1.6 liters, which is 9.6 liter.
Good.
And the
what about the QS?
QS is 14.
So probably QS is 14.5 minus 9.6.
No, the value which is subtracted from 14.5 to 9.6, which would be 5. So 9.6 liter is going into the pulmonary circulation, and the remaining part, which is approximately 5 liters, 4.9 liters, is going to QS. So the ratio would be 9.6 by 4.9, somewhere around 2, sir. Like 2, yeah, 1.97.
Perfect.
Excellent, excellent, superb. So can you also tell me why this lung, why is the left lung getting just 2 liters and why is the right lung getting 7.6? Also look at the angiogram, the image itself to see if you can make sense of that.
Probably because of the stenosis,
which we mentioned.
The stenosis is on the right lung collateral, right?
Yeah.
So still, that seems to be having higher flows, right? Why?
Yes.
Hint, patient is 18-year-old.
Sir,
okay, in the interest of the time, we'll go ahead, right? You've done well on the questions. So we see that the right versus left is like 3.8:1, right? Despite the fact that the left lung collateral is a huge collateral, whereas the right lung collateral is a stenotic collateral. So what is likely to have happened? It's likely to have been differential Eisenmengerize. Yeah, the pulmonary vascular resistance of the left lung would have been much higher because it was facing these unrestricted flows, right? So with the help of the MRI, you were able to actually distinguish that the two lungs are facing two different kind of resistances and two different kind of flows. So that's the message that should come
across. Just show the previous image, Mahesh, just show the previous image. So you see the richness of the vasculature on the right side versus paucity of vasculature on the left side.
Probably sort of pruning. So yes.
Yes.
Okay, go on. Go on.
So I think the team deserves full 10 marks.
Yeah, absolutely. Let's go on.
Okay, they've answered it well. So going to the next question. This is a 10-year-old child. He is essentially asymptomatic except for some mild effort intolerance. saturating 97%. He's got a 3/6 ejection systolic murmur. Simple, straightforward question. Can you tell what the morphological diagnosis is on the MRI cine images?
Excellent. Really, very good example.
The timer is running, I suppose. So look carefully at the anatomy and answer.
Sir, the cine images are showing RA draining to RV, LV is opening into aorta, and RV is opening into pulmonary artery. PA is showing some narrowing above the valvular level.
I think
probably
it's incorrect. I'll give you another chance. I think you're in a hurry. Just
look carefully at the morphology.
Carefully look down, because I've said it incorrect so quickly. You should understand why I did that. You got to see the first frame.
Sir, it is a corrected transposition, sir. The RV is on the trabeculated ventricle is on the left side, and aorta is L post. RA is opening into LV, and there is
corrected transposition with
intact ventricular septum and
and mild PS, right?
Mild PS.
This resulting from probably subpulmonic obstruction. Okay.
Subpulmonic obstruction.
Right. He can't help
So how many points should we give them? We gave them a second chance, so should we give them 5?
Give them 5. So in all fairness, we should give them 5, but because they made a serious error the first time, so I think that should not be condoned.
Okay. Last question. 14-year-old cyanotic girl saturating 76%. Look at the images and interpret the findings, and for bonus points, tell what would be your management strategy. What is the modality, first of all?
Sir,
what are the findings?
It's CT scan, sir.
Yes.
CT, okay.
Just we'll have a look, sir. 2 minutes.
Please take your time.
Okay, you want to have a shot at it now? Okay, Tanmay and Nishchal need to start answering now.
Yeah.
Unmute yourself, please. Just come up with describe the findings and describe the, or even you can just state the diagnosis, and then we can talk about the management.
There's a right-sided aorta, sir. Descending aorta is on the right side.
Okay.
That is the least significant of all the findings. Okay. What's striking about the aorta? Even that you can say, and then what's coming off the aorta?
Aneurysmal ascending aorta.
Okay. Dilated. Aneurysmal is probably exaggeration. Then what is the diagnosis? Underlying condition.
I'm scrolling slower so that you can see.
I think we should, okay. I think Tanmay, get it, we'll move on.
I think we have exceeded 1 minute.
Yes.
Tanmay, can you start, please? Otherwise, we'll move on.
So our diagnosis will be, sir, dilated ascending aorta with right-sided aortic arch with dilated coronaries. Sir, this looks like, sir, aortoarteritis, sir, is what?
Wrong answer. Can you move on?
Wrong answer.
I think you won't be given points here. I'm sorry, you won't be getting the points for the imaging modality. You made a mistake here. Can we move on to team 1?
Is it pulmonary atresia with the intact IVS?
Pulmonary atresia with?
Intact septum.
Why should it be intact septum? Again, you're conceptually making a mistake. I don't think you deserve bonus points for that. Pulmonary atresia is all right, but saying intact septum is conceptually incorrect. I think we will terminate it here. We cannot move on, and we will have to give Mahesh. Can you describe the findings?
So you can see here that it is pulmonary atresia indeed. You can see the pulmonary artery stump, but it does not communicate with the ventricular mass. You can see the branches going, and then from the right aortic arch, you can see this bunch of aortopulmonary collaterals coming. Can you see that? From the middle of the thoracic aorta, you have a bunch of collaterals which are going to both the lung fields. So this is pulmonary atresia with aortopulmonary collaterals, major aortopulmonary collaterals, and we would need to define these collaterals much better.
Get this only in tetralogy.
Yeah, through multiple modalities, we would look at these collaterals and we would try to decide if the anatomy is suitable for a unifocalization surgery or not. So there are multiple decisions that come downstream to this. So this is top pulmonary atresia, right aortic arch with map card.
And you don't get the intact ventricular septum, Kritika, you cannot get these kind of collaterals in intact ventricular septum. It's always associated with tetralogy. Okay.
Okay. So,
all right. So I think we'll stop at this. Take the audience question quickly. Mahesh, shall we skip the round because in interest?
We can go ahead. We can go ahead. Dr. Rajesh can take over from here.
Okay. So I think we'll first display the scores, please, at the end of this round.
Dr. Shruti?
Vishnu, and then
Yes.
Dr. Taragan, you want to say anything at this stage, sir?
It's okay. It's going on screen.
Thank you. So
Dr. Shruti, can you please display the scores?
Yeah, allow me a moment. Just a second.
Okay, I think. Yeah.
So team 1, 10 marks, and team 4, 10 marks, team 5, 10 marks, and team 2, team 3 is 0 for this round.
So, sorry, this is the slide. Team 1, 10 marks, team 2, 0 marks, team 3 is 12 marks, that's 10 plus 2 bonus.
Okay.
Team 5 and team 5 has 0 marks.
Sure. Thank you.
All right. Next. Okay.
Sir, I'm keeping the track of time separately. I'll tell you, sir. I'll indicate.
We will have to move faster.
So, sir.
Yes.
So we'll give 60 seconds, sir. 60 seconds, 1 minute.
Yeah.
Sure.
Okay. Yeah. Good evening, everyone. Hope I am audible to everyone. So I'll straight away move with the first case. It's a 64-year-old diabetic male with acute MI 10 days back. So look at the history carefully. Acute myocardial infarction 10 days back, conservatively managed, and CMI is requested to assess the viability. Your time starts now.
You have got 1 minute. This question is redirected to team 5.
Team 5.
So the order will be team 5, 4, 3, 2, 1.
Okay. So you can now start describing it so that I can give at least some mark, even if your answer is wrong. Team 5. History of MI 10 days back, MRI to assess viability.
Yes, sir. The first sequence is a bright blood cine image, 4-chamber view, which is showing the apex apical lateral wall is hypokinetic. Mild thinning is there. Septum is moving. Lateral wall is absolutely akinetic, sir. Lateral wall is akinetic.
Okay, good. Yeah, that's enough. Yeah, bottom two.
Sir, bottom. Sir, bottom is, sir, the apical lateral wall. This is the, sir, LG sequence,
Yes.
which is showing a transmural scar of lateral wall, sir. The apical lateral wall, while mid and basal lateral wall is okay. Septum is also okay, no scar.
You are partly right. Yeah, you told transmural scar, partly right. Any other important finding? Look at the images carefully, just the lower two images, these two images. You are right, it is a lateral wall infarct showing a significant hypokinesia. Thinning is there, mild, not much.
Sir, and there is a presence of pericardial fluid, sir.
Yeah, that is there, minimal, but what is more important regarding the viability?
Sir, viability, sir, transmurality will not be viable. That where the transmural is, while the
now, how infarct will appear on a delayed enhancement scan?
In fact, sir, more than 50% will be non-viable, sir.
No, in fact, how it will appear, either bright or dark?
Bright, sir. Bright.
Yeah. So how is it? Is it homogeneously bright?
No, sir.
Then why do you say it's transmural? Yeah, you are right. You are correct. But why this is appearing black, but still why do you say it is transmural?
Sir, this is transmural, sir, because it's acute, sir. It's acute MI which is showing edematous myocardium, sir.
Now I'll move on to the next team. If they can give, anyway, you can get a 5 mark.
Yes. Team 4. Team 4.
4.
Sir, it doesn't appear transmural. It is less than 50%, so viable myocardium.
No. Next team.
Team 3.
It's predominantly subendocardial LG, sir. So
no. Next team.
Team 2.
Just answer. What is the important finding here? What is this dark area represents? It's bright here. It is bright here, but in the center is dark. This darkness is different from here. Is any other team?
Team 1.
Sir, is it no reflow?
That we can call it, sir, intramyocardial hematoma.
No.
Okay, so that is so only the first team, team 5, get a 5 mark. So this is very important to understand. See, normally an infarct should appear homogeneously bright, full and full, but here it is the inner endocardium is bright, outer part is bright, but the center part is dark because this is indicative of a microvascular obstruction or a no reflow phenomena. Okay, so this is very important to understand. Okay, so many times you might have done angioplasty for a successful angioplasty to open up, but understanding this microvascular obstruction or a no reflow is very important because you are opening up only the epicardial coronary arteries, whereas the microcirculation is not different. Okay, and people usually confuse between infarct and a thrombus versus the no reflow phenomena. See, infarct should appear, transmural infarct will appear like this, homogeneously bright. Here what we are seeing is because the central part, the contrast has not reached because of the microvascular obstruction, we are getting this dark area. Okay, and this is how a clot will appear, that will be inside the cavity, whereas this darkness is in the myocardium. So that is, if you give a little more delay of, normally you will take about 5 to 10 minutes after contrast injection. If you take 20 minutes or a 30 minutes scan, even this also will fill up. So this is a no reflow phenomena or a microvascular obstruction. Very good. So we'll move on to the next team, team 4.
Team 4.
Yeah, this is a 53-year-old female with recurrent palpitations. ECG showed junctional tachycardia. Your timer starts now.
Your 1 minute starts now.
You can just start describing the findings. I'll give you a clue, and you know the history.
Sir, first one is cine 2 chamber view. It was showing basal thickness.
Yes.
And the second and the lower images or LG images were showing late gadolinium enhancement along the basal and the inferior.
Okay, good. So your findings are correct. What is the diagnosis?
Probably sarcoidosis.
Why do you say sarcoid? Why not infarct? See, when you see delayed enhancement, you think of an infarct. Why this is not infarct?
So thickness.
Yes, thickness is increased. That is one. Then, what are the other difference between infarct and the non-infarct scar like a sarcoid?
And territorial involvement.
Yes, good, very good. Then anything else regarding the whether involvement of the subendocardium, mid-myocardium, subepicardium?
Subepicardial, sir.
Which one? Subepicardial.
Here.
The infarct, how it infarct will be subendocardial.
Subendocardial.
Here it is predominantly mid-myocardial, almost transmural, but relatively sparing the subendocardium. Okay, that is a one. Then any other finding? If you look, what is this structure below the diaphragm on the left side? This structure.
Below the diaphragm.
Below the diaphragm, left side.
Spleen, sir.
Spleen, yeah. So normally spleen should appear homogeneously dark, but what are these? Yeah, these are all enhancing granulomas in the spleen also. Okay, so you get anyway full mark. It's your answer is correct and your description also is correct. Okay, so you need not look only at the heart. You have to look at the other areas also, which will give you an important clue. And any other area you want to see in the MRI when you are suspecting sarcoid? Which other area you want to see?
Lymph node.
Mediastinum.
Mediastinum.
Which mediastinal nodes are commonly involved in sarcoid?
Hilar lymph nodes.
Yes, bilateral symmetric hilar nodes. Okay, so here you can see that these are all the bilateral symmetric hilar nodes. Again, showing the edema and the lesions in the spleen. Okay, characteristic of a granulomatous disease. Okay, so it need not be a sarcoid. If you say granuloma, is fine, either TB or a sarcoid. Very good. So you get a full mark. We will move on to the next team number 3. Team 3. This is a 45-year-old female with the history of idiopathic thrombocytopenic purpura, presented with dyspnea and exertion, and echo showed LV mass. Cardiac MRI is requested to characterize the LV mass. So you know the history. And your time starts now.
You have got 1 minute. Sir, I'll just keep track of time.
Please do.
In the interest of time.
Yes,
yeah.
we are
yes, you can start describing so that I can give some clue. You can come to an answer.
Yes. So the cine sequence in the initial one is showing pericardial effusion, and we can see in the center there is a mass, the LV mass, which we are saying of, and there is no actually in the third image we can see that there is increased vascularity to the mass also. And
you're talking about this image?
Yes, sir.
What is this sequence? Any idea?
LG sequence.
No, that is not LGE.
Perfusion sequence.
No, this is stir image. Okay. What is this one? Yeah.
Time's up for team 3, sir.
Okay, so just a diagnosis. Otherwise, we'll move on to the next case. I mean, next team. Okay, next team.
Team 2.
Is it RV myxoma?
RV myxoma, no, wrong. Next team.
Team 1.
Sir, it's an intramural hematoma, sir.
Intramural hematoma. Yes, within the cavity, no? The mass is within the cavity.
Yes, sir. Large clot within the LV apical clot, sir.
Yeah, you are right, but why do you say it's clot?
So in the base, the patient has a history of in the basis of ITP history actually.
Yeah, only based on the history you cannot diagnose. No? What is the MRI finding? This one and this one. Very important. This is the LGE.
Inversion. It is not the clot is not taking up the contrast.
Yes, good. Okay, so clot is not taking up the contrast. That is a very important thing. So you get a 2 bonus point, and to confirm that, you have to do a the delayed enhancement with a very long inversion time. So this is a TI with a 600 millisecond. So where you won't see any enhancement within the mass. That is the most characteristic of a thrombus. Whereas if it is a myxoma or any other tumor, it will enhance. Okay, so these two are the delayed enhancement. This is a stir. Usually the lesion will be appear very bright, here only mildly bright, whereas myxoma will be very bright. But the most characteristic thing is non-enhancing LV mass in the background of ITP, but the characteristic is non-enhancing. So especially on a inversion time of 600 millisecond is characteristic. Okay, good. You got 2 marks. We'll move on to the next team, team number 2. Okay, so these are the difference between thrombus and the tumor. If you want, you can take a screenshot, as well as the difference between benign and malignant. The important thing is generally malignant lesions will have a hemorrhagic pericardial effusion. Even though in this patient has a pericardial effusion, but still it is a benign condition. Case number 4 for team 2. It's a 35-year-old female with evaluated for tricuspid and pulmonary valve pathology. Echo-wise, there are pathology in the tricuspid and pulmonary valve. There is no history of rheumatic fever. Both mitral and aortic valves are normal. Your time starts now.
You got 1 minute.
Just you describe the views and the finding so that I can give you a clue.
Is team 4 or team 5?
Overview showing severe TR, sir.
Yes, good.
Team 2.
This is for team 2.
Severe PR, sir. The third image is severe PR.
Yes.
Given the history, sir, it could be a carcinoid syndrome because it is affecting both the
only history, imaging findings. Okay, so I'll show you the still image. What does this scan shows?
There is a hypodensity, sir, seen in the.
Okay. Yes. Anything else?
And in colon also, so it is be a carcinoid.
Okay, good, very good. So excellent. Yeah, so we got all the findings. You are right. And what is the finding here is it's not just a regurgitation. You can also see the thickening of the valves, isn't it? So there is significant thickening of the valves, the homogeneous smooth thickening, as well as both stenosis and regurgitation associated with the. This is a ileal carcinoid, ileocecal junction level carcinoid with the liver metastasis with the carcinoid syndrome. You get full mark. Team 2 get full mark, 10 marks.
Sure, so thank you.
So we'll move to the last case, team 1. It's a 47-year-old male, dyspnea on exertion class 2 for the past 6 months and on and off paroxysmal palpitation. Patient also documented monomorphic VT. Catheter angio showed single vessel disease, about 80% stenosis in the proximal OM2. ECG showed sinus rhythm with Brugada pattern. Echo is reported as normal. Okay, your time starts now.
You've got 1 minute, team 1.
Can you just identify the sequence under the finding? You know the history. Just if you identify the sequence under the finding alone, you can get some mark at least.
Epical 3-chamber view.
Okay.
Epical 3-chamber view, sir.
What is the sequence? You are saying the view, but what is the sequence? If you identify the sequence only, then you can identify.
T1 meter.
No. I'll tell you this is delayed enhancement sequence, LGE sequence.
Okay, sir. Okay, sir. Yes, sir. Yes, sir.
So what is the finding?
15 seconds remaining for you, team 1.
Yeah, this is the full set. So these two are the LGE sequence. So any finding?
Sir, epicardial and epicardial late gadolinium enhancement is present, sir.
Okay. So look at all the images and what is the final diagnosis?
Time's up for team
Okay,
1.
next team.
Team 5.
Just a diagnosis.
Sir, this is myocarditis related scar.
No, you are wrong. Next team. 4.
Team 4.
What is this image?
Skeletal separation.
That is
You can identify the sequence, then you can tell. No? This is a PET scan, isn't it? This is PET, it's not MRI. Any finding in this? Okay, we'll move to the next team.
Team 3.
Is it sarcoidosis, sir? Like
why?
Subepicardial LG, and even the uptake is seen in lymph nodes as well as glands in the.
Yes, good. So you get a 2 bonus marks. So these are all the lymph nodes, cervical lymph nodes as well as mediastinal lymph nodes. Okay. So again, this is a granulomatous disease. You can classically see that this is a non-ischemic scar. Again, showing a classical subepicardial dense scar and the T1, T2 mapping, showing elevated T1 and T2 value. And the PET scan shows the mediastinal under the cervical lymph nodes. Actually, this patient showed MRI, PET MRI showed a coagulating necrotic conglomerate lymph nodal mass, and finally turned out to be TB. So difficult to differentiate TB from a sarcoid. Okay, so you get a bonus mark 2 point.
And sir, how much marks for team 1?
Team 1 just they said partly, so 5 mark.
Okay, thank you. Team 1 5 marks and team 3 gets bonus 2 marks.
2 marks.
Thank you.
Yeah.
We will
Last
keep
two.
the audience round, sorry, because we're just running short of time.
Okay, sir. Okay, sir.
And we will move on to the next session because the coronary angios are also very good. Thank you. I think, Rajesh, it's been fantastic. This case is really good. Thank you so much.
So I'll just request Dr. Shruti to quickly display the scores after round 4.
Yeah. We don't know the cumulative scores, but that's okay.
Yeah, yes.
Is there an audience quiz? KK, is there an audience quiz?
No, I didn't keep it. I'm skipping the audience quiz in the last 2 because in the interest of time, we're running behind terribly.
Okay.
So
right.
Team 1 12 marks, team 2 10, team 3 2, team 4 10, and team 5 5 for the after the round 4. And this is for the round 4 marks only.
Okay, let's go on to the.
Thank you.
Thank you, Dr. Srinivas. These are again, this is a very, very special round. Huh? Lots of very interesting cases because we went through it with Dr. Srinivas.
No, all our students have gone through really tough rounds where even probably I wouldn't pass. I won't get pass marks, but it will be very easy to. So I think I'm sure this whatever I am going to show they're all very easy ones, and I'm sure all of you will get through it very easily. But I think we are going to have 1 minute for the answer time. I think the time to give the answer. I think I will not to waste much time. I'll start with the.
And so the order will be team 1 2 3 4 5.
Okay, this is the first angiogram. The 56-year-old with an evolved inferior MI who was referred for angioplasty to right coronary artery. And you can see that that's what has been done. You may watch the angiogram. Okay, what do you see here? The timer may start now.
Your 1 minute starts now. I'm keeping the track of time, sir.
Yeah.
And this is to team, which team?
Team 1, sir. Team 1.
Okay.
I will follow 1 2 3 4 5, sir.
Sir,
You've got 30
image,
seconds.
It's a LAO view, sir. First image. Distal RC occluded, sir, in the first image. So post stenting, there seems to be. Stent is deployed in the distal RCA. Stent deployed in the distal RCA, sir. A part of the stent distal.
Time's up for team 1.
Team 2.
Okay, I'll pass it on to the next team.
Team 2.
It is the LAO view.
I'll be giving any marks for the team 1. Yeah, we'll pass it on to the next team.
Post PTCA, sir, the distal RCA appears to be widened. Maybe because so this is the splayed RCA sign, sir. Seen because of aneurysm, sir, most probably basal aneurysm.
Okay, you appear to be getting it right. Well, it's a large basal aneurysm causing splaying of the PLV and the PDA. So it's called as a splayed distal RCA sign. And you can also see the systolic compression of the posterior descending artery, which is being compressed by the aneurysm. It's a sign which we see when there is a big basal aneurysm. In fact, there is an article on the same which has been published in Indian Art Journal from Delhi, from Safdarjung Hospital and AIMS. The splayed distal right coronary artery sign. Maybe the team 2 would get 2 marks for this. I think,
bonus marks. Thank you. Yeah.
Bonus marks. We'll move on to the next question, which is for team 2, right? Yeah.
Team 2 only, sir. Team 2
Team
only.
B.
Yeah.
Team B. Okay. It's a coronary angiogram, a post-CABG patient with angina. This is the angiogram, native coronary angiogram, followed by the further evaluation. What is happening here and why? Timer may start.
You've got 1 minute.
A simple one.
So the first angio is of right femoral artery approach, sir. Seen in a RU cranial view, showing native vessel. The proximal LAD has around 80 to 90% stenosis. The second shows cannulation of the lima, which appears to be occluded. There is a steel phenomenon, sir.
Okay, I think I'll give it to you.
We should grant it to them, sir.
Yeah, you should give it to them. I think the first film shows the answer to this is, yeah, it's an occluded LAD which is being collateralized by the RCA. And you can see the second one is the occluded RCA, occluded LAD. And there's the lima stele causing atresia. Lima is atretic stele of blood from lima, and the LAD graft by the side branch, which was not properly clipped during the surgery. Just stresses on the importance of clipping the side branches while harvesting lima while taking the graft. So LAD being poorly perfused from the homo and heterocollaterals, we have, the lima stele is evident here. Well, in fact, this patient had also undergone a post-op day 2 angio because of some atypical pain. That time you can see that the lima is flowing well. The LAD is still having a competitive flow. In fact, you can see that the side branches have already started becoming big. So this is on the day 2 of the CABG, what you can see here. And now when the patient presented subsequently with angina, this is what you have seen now.
Okay.
Okay, I think we'll move on to the, I think the team 2 would get 10 marks. They got the answer right. We'll go on to the third angiogram. This is to team 3. You may identify the abnormalities and what is being demonstrated here. Timer may start now.
Yeah, you have got 1 minute. Team 3.
Sir, the first the angiogram which is being done is the right coronary injection, which is showing an occluded coronary, and probably and the other catheter which is there is actually looking like as if it is going from RVOT to PA.
Good.
So what is
Time's up for team 3.
Okay.
So let them complete it. They had started
Okay,
it.
sure.
You may take another 15 seconds.
Yeah, please.
They have not come on to the main abnormalities, so I think we'll move to the next team. They will not get any marks.
So here,
team 4.
Team 4.
It's a right coronary angiogram in LAO view with one catheter placed across the RVOT, and it is demonstrating right coronary is occluded, and a large branch is originating from RCA, which is crossing the RVOT, sir.
Yes, and supplying what?
And supplying the conal branch, sir.
But where does it go eventually?
And eventually it comes down again and supplies the AV group.
No, incorrect. Team 5.
Okay, we'll go to the next team.
Team 5.
Team 5.
Sir, this is right angio as RCA proximally totally occluded. Conus is enlarged, and conus is supplying its distal course of RCA. I guess this is sir collateral, sir.
Wrong. We'll go to team 1.
She's unmuted.
No idea.
We'll go to team 2.
Team 2, sorry. Yeah.
Team B. Yeah. Okay, I think we'll move on to the answer. In fact, it's an anomalous LED arising from the proximal RCA, which is occluded. Note the septals being given off as the artery courses along the anterior interventricular groove. You can see the other angiogram also, in fact, displaying it. The catheter in PA shows that the artery is crossing anterior to the RVOT and is not having an interarterial course. I think nobody gets any marks, I guess.
Yeah, no, I agree. Nobody gets.
Okay, fine. We'll move on to the fourth question. I mean, in fact, we do the CT to identify the interarterial course or the how the artery is coursing through whenever we see anomalies. Many times, I mean, in the cath lab itself, we can clearly demonstrate it by keeping a catheter in the RVOT and the pulmonary artery. Okay, we'll move on to the next question. The fourth question, this is to team 4.
Yes, sir. Team
4. Okay. Identify this is the right coronary angiogram. Identify the key abnormalities and what is the diagnosis.
Your time starts now.
Time starts now.
This is right coronary angiogram, and there are no flow limiting lesions in the right coronary artery, and that is showing filling of the right ventricle as we move forward, probably a right coronary cameral fistula. RCC to RV, sir.
Move on.
Okay, we'll move to the next team. They have not got it right. Team 5.
Team 5.
Unmute Tanmay and then answer. If you could get the answer, say yes. Otherwise, move on.
You've got sufficient time. We should quickly come out. Otherwise, we'll move to the next.
This is RCA duplication.
Let's move on.
Okay, now move on to the team 1, team A.
Is there a perforation, sir?
Wrong.
No. Okay, team B.
Team 2.
Team 2. Yeah, team 2.
Muted.
No, sir.
Okay, team C.
Sir, is it a calcified pericardium and fixed coronary?
Absolutely. Yeah.
Absolutely.
So we give them bonus marks.
You're right. They will get the bonus marks.
Yeah.
In fact,
Team 3, 2 marks.
It's an entrapped RCA sign seen in constrictive pericarditis. Then extensive heavy groove calcium you can clearly see there. The case of constrictive pericarditis. Well, I think we'll move on to the last question. This is for team 5. You just look at the angiogram first. This is a patient, 42-year-old lady who had recently undergone a primary angioplasty to a lady presented with rest angina. As obviously you can see in the angiogram, the patient has a stent thrombosis and the right coronary angiogram, and successful reopening of the artery was done. And this is the, after the wire was removed and the final shoot on the right. Interpret what is happening here. Timer may start now.
Your time starts now. 1 minute. You're at 1 minute.
Hope you're seeing the full image screen, because I am not seeing the top line.
It's shaking a little bit, but I don't know if it's going smooth or not.
Okay, anyway, what is happening here?
You can freeze the one on the left and you can allow the one on the right if it's easier to see that way, because the movie is jagged a little bit. It's not smooth. It's going to be hard for them to interpret.
Could you just
LMC dissection.
LMC dissection. Okay.
Team 5, 1 second. Kate sir, could you reshare the screen, sir? This will become better because the video is important.
Is it okay?
Reshare the screen. I think to be fair.
Stop share and then reshare.
Okay, I'll do that.
Go to slideshow. Slideshow.
Yeah, I'll go now. Okay.
It's the same story.
Is it? Okay.
Sir, whatever we can see, we can give, sir, 2 DDs for this. Either LMC dissection or the thrombus from stent has moved upward and causing LMCA compromise, sir. This is what.
No, I think
thrombus. Okay.
No,
okay, what is happening in the, I'll just lead them to the point of interest. What is happening in the distal LED?
Distal LED, sir, it's not reaching till apex. So
it reaches till apex, and then what happens after that?
You're not able to trace.
Yeah, it's tough on them. I think it's very difficult because it's not visible.
I'm sorry. Okay, we'll move on to the next team if they can.
No, I think I think we'll leave this question. We'll take question 6, which is the audience round questions, and offer it to team 5 again, and maybe that will be fair to them.
Okay.
That's possible.
Okay, fine. Yeah. Okay, but we'll not give the choices. Okay.
We will not,
fine then.
not give the choices.
Fine. Okay. Anyway, I'll just answer it. There is an ostial left main lesion causing the catheter wedging, preventing forward flow of blood, and the RCA collaterals are emptying the distal LED the retrograde manner. Okay. Fine. Anyway, we'll give this question to the team 5. Okay.
Yeah. This is also not going well, but it may still be possible to interpret.
What are all the abnormalities that you can think of? I'll ask you to at least identify 3 or 4 abnormalities. Or you can take open-ended. What all you can see, you can tell.
And it need not be in sequence. You can change it also.
Identify the abnormalities. Okay.
Time has already started.
The third video is so that is showing anomalous anomalous LCX. Anomalous LCX originating from RCC. The third one.
20 seconds remaining.
You got one bit right, then you can now look at the other bits. Yeah, almost done.
Clears the first one.
Time's up for team 5.
The RCA has
we'll hold the marks till the end. We'll go to the next team. Maybe that is team 1. Then we'll also have the audience pool probably for the choices.
Yes.
Team 1.
Uh,
10 more seconds.
The marks may be decided by Dr. Taragan sir for this, because we'll also have the audience pool. At the end, you may give the marks to the team.
It's a very good one, Srinivas. You didn't show me in the old collection when we reviewed the.
Because you tried to select a question for audience, it was very tough because you had to give multiple choices.
Yes. But this is a very good one, really good one.
Okay. Next team, team B.
Sir, in the third image, the left circumflex is originating from the right.
That is answered.
Vessel.
That's done.
And it appears to be following a retroaortic course, sir. And the distal, in the second image, the distal LAD, some thrombus can be seen. In the first image, there is a dual LAD in the first image, sir. When the lower LAD is giving the septal branches, the upper LAD is giving the septal branches. And the lower LED is supplying the OM territory.
Okay, you have added one more point. Okay, but not all are complete. Okay, we will also still give to the chance to the next team. Team 3.
Team 3.
Then probably will close it. Yeah. Anything else apart from what they have told?
Team 3 and 4 are left, sir.
Okay, team 4.
Sir, team 3, sir. Like also a dominant LCX.
Good. You qualified it. And I think most of the things have been identified. Team 5, team 4, anything else you want to add? Okay, I think we'll go to the audience poll.
Before we do the audience poll, okay, we can show the audience poll and then we can.
We'll go to the audience poll and then.
Sure.
Just to give the
I'll launch the poll, sir.
What is not true about this set of images? When they've seen it enough, they can quickly answer. So 15 seconds.
Sir.
Okay, the majority have said probably aortic stenosis is a wrong answer, and quite a significant number have said none of the above is the right answer. Well, pardon me? Yeah, I think nobody can diagnose aortic stenosis on that angiogram, but nevertheless, yeah, you can take off the screen so that I can go to the next slide. Yeah, 4th and 5 would be accepted. 5th would be the perfect answer. I'm not able to move the screen.
That's okay. I think we'll decide on the marks for this round because I think team 5 got one part right, maybe. So you want to give them 5 marks?
You can see the heavy calcification of the aorta. This was a case of aortic stenosis where we underwent a pre-surgical angiogram. It was a non-dominant RCA, dominant circumflex anomalously arising, and the LAD has a lesion, distal coronary lesion. Okay, I think the marks, I think the one of them gets 2, I think.
And team 5 got one part right. So would you want to give them 5 or nothing?
Team 5 just identified the dominant circumflex. You can give 5 marks for them.
Okay. All right. So we'll wind up the quiz. And while the marks are being calculated, I'll ask Dr. Taragan to give his final comments on how it went and how we can do this a little better. Of course, we enjoyed, of course, and learned a lot, but I want Dr. Taragan's comments.
Yeah, I think the message is very clear. Quiz is only just adding a bit of excitement and involvement. Otherwise, most of it is the learning lessons, and I think all of them have been very good. Of course, the echo session had been substantially tougher than what we generally see. All other sessions, the remaining 4 sessions, were fairly okay. I mean, obviously, it could sort of differentiate a person who is familiar with the imaging rather than the one who is only seeing the imaging done by someone else. All said and done, I think this has been a very good exercise, and obviously I must congratulate all the faculty for the excellent collections from them. And I'm sure the fellows will take home sweet memories, extremely important learning points, and I think they'll have to look a little wider than the routines for the PM examination. Exactly. That I think is important. It is not just one of the very odd cases. I think these are ones which could come maybe 1 in 100 or even less, or I mean not as rare as what we would have thought. I think it has been an excellent session, Professor KK, and I think we can wait for the results. But as I said, the results are not important. I think all of us have enjoyed, and all of us have become the winners in this fantastic test.
The one thing I wanted to notice that, things like calcification, you tend to miss. I've seen the students don't pay attention to simple things, that RCA calcification, AV group calcification, aortic root calcification.
Yeah, that's right.
These things we tend to miss outside the heart, you don't see. That's also very important to look at it. So little bit Dr. Taragan's message that broaden your vision, be open, and pick up things, clues from everywhere. And that's the essence of medicine anyway. So, are we ready with the results?
Sir, can I know just if team 1 gets 2 bonus points for that last round?
Yes, they do, isn't it?
So then, yeah. So then, sir, we have to just work it out again. Just a second, sir. Just a second.
It's a tight call, looks like.
Sir, it's a tight call. Yeah, it's a tight call. That's why I just want to confirm that. So
just
team 1 gets 2. Yeah. Dr. Shruti, team 1 gets 2 bonus marks for the last round. So please add on. And then just let us know who is the winner.
Prabhakar, you want to make any comments at this stage? We can even take some opinions from the students. Dr. Srinivas, I actually learned a lot. What did you think? The students can give your views on how this session was. Did you enjoy this process? Did you think it was educative? Tanmay, Rohit?
Yes, sir, we really enjoyed. And the whole concept of round 1, round 2 to round 5, all rounds very educative. We are really thankful for giving this chance. Sir. Thank you. Sir.
I think echo is your deficiency really, and that was all of us was challenged in that echo round. They were very tough.
Yeah, very tough questions. So I don't think we can say that it's
well within our reach. That's the only thing. While MRI, of course, the imaging is done by the radiologist, and we generally see the films, and usually the various sequences we generally get lost unless we ourselves have learned to acquire the sequences and interpret. So I think otherwise the other 4 groups of study, questions were quite fairly reasonable.
Okay, can we have the final score? This is
just so this was the round 5, and now the winners.
Oh, this is very close.
Very, very close. Okay, so the winner is okay.
So team 1
by 1 mark. Congratulations.
Thank you so much. Thank you so much. Sir.
We'll all be giving certificates to all the participants, and then we'll figure out a way to award you or reward you rather.
Thank you, sir.
Thank you.
Yeah,
And being a part of
congratulations.
this is a
We'll get a secret and surprise prize will be sent to you.
Okay, their addresses have to be collected by the team. Okay. Thank you all. Thank you, Dr. Taragan. Dr. Prabhakar, closing comments, and then we can wind up.
No, what can I say? I mean, this was really good. I learned a lot, but obviously that doesn't mean anything because I don't know much now. So it was really very good. And hopefully this enthuses all the fellows and the students and brings more of them. So you should talk to your colleagues and tell how you enjoyed this. We will have variations of this as we move along, but we'll keep this going so that it sets people also thinking. I mean, it's not that we just showed exotic cases and then they came up with diagnosis, but it sets thinking. There was a discussion here, and I hope everybody enjoyed this. Back to you, KK.
I think the next grand round is going to be on multivalvular heart disease, and we'll do it slightly differently. We'll have a case example, but not too long. Then we'll have a lecture on clinical approach on multivalvular heart disease and a quiz. So the same kind of thing, which I think a lot of students can look forward to learning. And that's on the 8th of October. So goodbye until then. Take care.
Thank you, sir.
Okay.
Thank you.
Thank you, everyone. Thank you for joining.
Thank you.
Thank you.
Yes, sir.
And congratulations to all teams. Thank you.
Team selected.